Hello, everybody, and welcome to our next public health forum. Today, we'll be talking about global surgery, what it means, and where does India stand when it comes to global surgery. And to talk about this, we have with us Siddhesh. Siddhesh is a dear friend. He's a mentor. He's a teacher, and he's also the co-founder of Association for Socially Applicable Research. So in a way, he's my boss as well because I work for the organization. And Siddhesh is a research aide in Duke University, and he's also an adjunct professor for research in D.Y. Patil University, Pune. So thanks a lot, Siddhesh, for taking out time and joining us today to talk about this extremely important topic of global surgery.
Of course, yeah. Thank you so much, Parth, for inviting me. I think we'll get started since we already.
So before we start, there's a small exercise which we can do before we get started. I just wanted to sort of understand everybody's perception when it comes to global surgery. And if you can just unshare your screen once again.
Of course, yeah.
Yeah. So I'll be sharing a link in the chat box. If anybody can just open that link and enter your thoughts of what comes to your mind when you think of when somebody mentions say global surgery. So the link is in the chat box now. You could also scan this QR code and start typing. Okay, so some people have mentioned affordable, expensive, equitable, accessible. Access is again coming up. Needed in India. I hope my screen is visible. Primary care, improving, research. People-centric training, timely treatment. So a lot of these things are coming up, and Siddhesh will be talking about most of these today. How timely treatment is important, how affordability is an issue, how it makes care equitable, and so I'll stop sharing my screen here. People can still continue to write their responses, and I can share it later as well. And Siddhesh, you can sort of go ahead and start with your discussion today.
Of course, yeah. Well, thank you so much for having me, Parth. I'm always excited to talk about global surgery since that's kind of like my main topic of research interest currently. And it's amazing to see like a whole bunch of people here who are interested in listening about this. Because I'm going to be honest, global surgery is still a new area. It's still somewhat neglected area. It's particularly neglected in these parts of the world, so India, South Asia. And as a researcher, as a public health scientist, policy analyst, yeah, whatever roles I'm kind of like, I guess, changing every day, it's difficult to talk about topics that people are not interested in listening, right? So thank you so much for being here to participate in this conversation. My kind of like goal today, and the reason to have this talk is because a couple of weeks ago I did like an informal poll on my Twitter asking, do people know about global surgery? And my kind of like Twitter network is still partial. It's mostly public health people. It's neuro people, it's surgery people. So even that, with like all the retweets and quote tweets and whatnot, after like 150 votes in like a day or two, I guess, uh yeah, about over 75% people in like the extended network did not know what that means. So that kind of motivated me to have this talk. And thanks to Nivarana and Parth for providing this platform. Okay, so we have a very simple outline for today, and I just have a singular goal. Out of all the 19, 20 people who have joined in, my goal is to show you that global surgery is worth doing, and that this is, if you're interested in public health, if you're interested in surgery, this is definitely something that you can think of. So we are going to cover some of the basics in the first part, and which is like the chunkiest part of today's discussion. We'll then move on to discussing a little bit about our work on surgical care in India. And then I kind of want to keep time for question and answers. And I'm hoping that we'll cover some of the things that I have deliberately not included in kind of like my slide deck in those question and answers. All right, let's get started with our Global Surgery 101. So, since it's fashionable these days to use ChatGPT, before the talk, here's what I did. I asked ChatGPT, what does it know about global surgery? And it came up with a very confident and expansive definition, talking about uh, surgical care provision in low and middle income countries where access to essential surgery is limited. It talks about safety, affordability, timely access. Kind of, if you think about it, it's using all the words that all of you have put into the word cloud, right? And that's I mean close to how it learns things as well. So but then it goes on to talking about integration of global surgery into global health and development, how the mission going ahead is towards strengthening of surgical care systems, training of surgical personnel, and addressing barriers to access surgical care, including lack of infrastructure, funding, and political will. So I was kind of really impressed that moving beyond the public health definition, it kind of was able to connect uh, global surgery as a domain to some of the other things happening around. So it came very close to what, as a researcher, I am trained to think of global surgery, but it kind of missed an essential point there. Let me see. I'm struggling to find my cursor, but regardless, okay. Uh, so I gave it a prompt that does global surgery only include low and middle income countries, LMICs? And it kind of stressed again confidently on the idea that yes, global surgery is about LMICs, but then it also kind of tracked back some of its statements and said that, well, beyond LMICs, it's also about disparities in access to care, which may be present even in high income countries and other populations, such as underserved populations in rural areas. So that's kind of more complete in terms of what we mean when we say global surgery. Diving more into that, I want to make it clear, this is a discussion that I have had with a lot of people, and I want to make one thing clear at the start, that global surgery is not about locations. The focus is not exclusively on low and middle income countries or low income economies. Uh, it's about disparities. So the idea is that we are looking at unfair differences when it comes to access to surgical care, and the broader idea going beyond biomedicine and talking in terms of development, talking in terms of policy making, politics. The idea is that we have, uh, metaphorically, we are using scalpels and sutures here to treat the fractures in societies, right? People not getting access to surgical care uh, is is not something that is supposed to happen. It's happening as a result of lot of inequities and injustices that exist in the global society. So if we are kind of trying to understand what's the goal of global surgery here, providing all surgeries for all people, that would be utopia, right? uh, Hopefully, maybe a few hundred years from now, we'll reach that point. Providing all surgeries to some people, that's the current reality. And that includes a lot of differences, and that includes a lot of disparities. Okay. But our idea is that we should be able to provide some surgeries to all the people. So that's kind of the main goal or ambition of global surgery as a field, and of all the people who currently are involved in global surgery. And there is a way in which we define the idea of some surgeries. And there are minor differences across different partners, collaborators, and stakeholders globally. But kind of in a major sense, people now agree on essential and emergency surgical care being accessible to everyone around the globe. All right. And I also want to clarify one thing quickly, that when throughout this talk, whenever I'm talking about surgical care, I'm kind of including surgery, obstetrics, trauma, and anesthesia. So if you look at the way people are talking about global surgery now versus the way they were talking about it 5 or 10 years ago, the more inclusive term that people like to use these days is SOTA care and not surgical care. So the final takeaway, the way we define global surgery and what it does is it's trying to universalize access to surgery, prioritizing those in need currently in order to ensure health equity, right? A final goal, the utopic dream is all surgeries for all people. But as we move towards that, we need to make sure that we are moving along the path which is equitable. All right. So global surgery, if you think about it, is not really a new thing. In some form, it has always existed since kind of like the dawn of surgery. Uh, Maybe some of the most initial examples that people like to talk about are surgical camps and medical missions that used to happen in underserved areas and underserved countries, where uh, people trained in allopathic medicine and surgery were not available. So people from outside used to come help out the communities. And this was an impactful way of helping the communities. It still stands as an impactful way of helping the communities. For instance, just few years back, I have kind of volunteered, participated in the surgical camps that happen for tribal people in my home state Maharashtra, in a part called Gadchiroli, right? So that's one way of doing global surgery. But that is, although impactful for local communities, it's not the best way for long term sustainable and systemic solutions and strengthening of surgical care systems in those places. So what we are seeing right now in like the past decade is a new spin to the old idea of global surgery, and it's kind of reinventing the core principles of global surgery, where we are moving away from this idea of uh, knight in shining armor coming to a place and saving everyone. And what we want to make sure that people who usually get saved have enough resources that they can save themselves, right? So that's kind of like the reinvention that we are witnessing. A major time point in this movement, uh, if the year of miracle has been 2015 for global surgery, due to multiple things happening, but I kind of want to focus on three main things right now. So one is that the World Health Organization came up with a resolution for strengthening emergency and essential surgical care and anesthesia as component of UHC. What the resolution did was that it kind of stressed on the idea of how surgery is important for health systems overall, and how health systems cannot actually operate or cannot actually achieve universal health coverage without integrating surgery. And remember that when we say surgery, we are talking about SOTA care. It also stressed on the idea of political leadership needed for improving and scaling up surgical care. And like the resolution was kind of unanimously signed by 194 countries in 2015. In the same year, Disease Control and Priorities Network, which is a research group slash think tank supported by World Bank, among other different funders and organizations, released a report on essential surgery, and it focused on a couple of things. So it focused on avoidable disease burden due to surgery, and that was like a big chunk of evidence that was required to make a case for why surgery, why access to surgical care is a big problem, right? It also did a lot of evidence synthesis on how scaling up surgical systems is cost beneficial, meaning that the money that you're putting into, let's say, building something or training someone has very high return on investment when it comes to surgical care. And then it also demonstrated that at least about 43 surgical care packages, which include essential surgeries, are highly cost effective, and we'll discuss some of these things later today. The third thing that happened, which added to the miracle, was the Lancet Commission on Global Surgery, or as it's commonly known as ALCOGS. And ALCOGS, among several things that it did, focused on a couple of things that were very important. It showed that a lot of people around the world lack access to surgical care. We'll talk about this just immediately after this slide. Uh, it kind of like also gave two deliverables then as to how access to surgical care can be improved through systemic ways. One was introduction of global surgery indicators that can track progress of how countries are developing their surgical care systems. So these are kind of more systems or public health kind of indicators, looking at different aspects of surgical care, mainly three aspects: so preparedness, delivery, and impact of surgical care on a given community. And then it also proposed the idea of national SOTA care plans. So these are kind of vertical policy action plans that are exclusively dedicated to SOTA care. Since 2015, multiple countries have gone on to devise their SOTA care plans, and multiple countries have now figured out a way to map their global surgery indicators. So I kind of want to focus next a little bit on why we should focus on global surgery. And I want to start with my personal reason. So my personal reason for working in this area is that I like to work on big neglected problems that can be solved but haven't been solved yet. Okay. The way we define these problems, and we have kind of talked about it previously in a comment piece, we call them end game problems. The basic idea behind end game problems is that these are the problems that we have probably neglected till now because we think or because we feel that they are very difficult to solve, or solving them is almost close to improbable, if not impossible, right? Uh, Consistent research in case of global health, in case of political economy and development, has actually shown that every single time that we have thought that something is too difficult to solve, we have been wrong about it. All right. So global surgery presents multiple such endgame problems which are interconnected to each other. Another way to look at endgame problem, and the reason I like to solve them, is something similar to what I think I also used to do as a kid, and it's called eating the frog. So basically, every morning that you wake up, you kind of know that there are a bunch of things that you have to do today, right? And some of those are difficult, and some of those are easy. Uh, the way to handle difficult things, I believe, for me personally, is that I want to do them first thing in the morning. So I want to do the most difficult, most unpleasant thing in the morning, so that rest of the day I feel much more comfortable. Uh, so that's one thing. The second thing is that in case of end game problems, the idea is that it's kind of very aspirational, right? It's kind of like a high reaching fruit. So even if we are not able to grab that, in the process we are going to be able to solve so many other problems that it's going to have a spillover effect on the rest of the health system and rest of the society. Okay, so now let's talk a little bit about why global surgery needs to rise to our policy agenda, our political agenda, and our general scale of importance when it comes to public health and social development discussions, right? So for a next couple slides, I'm going to try and make a case that global surgery is one of the biggest problems in the world that is there to solve. So let me start with mortality problem as a component of problem magnitude. First statistic that I want you to focus on is on the left of the screen. What we know is that when it comes to the mortality burden of all the conditions that can be treated surgically, that burden kind of goes above 16 million deaths annually, and it's more than the mortality burden of TB, HIV, and malaria combined. Okay, for a long time, till this piece of evidence came out, what was considered was that infectious diseases, particularly TB, HIV, and malaria, which are considered the unholy trinity of global health, uh, have so much burden that it's very important to solve them before we move on to solving other problems, right? Again, thanks to research, we now know that that's not actually true. When it comes to, given the breadth of where and how surgery can help, it's not specific to just non-communicable diseases. It kind of like transcends those boundaries and goes into uh, communicable diseases, non-communicable diseases, injuries, with regards to like type of disease classifications. uh, Surgery is important across different age groups, across different genders, across different locations. Different kinds of surgical specialties are more important in specific regions, right? So across its like depth and breadth, there is a huge mortality when you do not scale up your surgical system. The second graphic on the right is about perioperative mortality. So deaths that happen either before, during, or after someone is undergoing a procedure, right? We now have data from NIHR, which is a UK organization doing amazing global surgery work around the world. The NIHR data pooled across over 170 countries now tells us that perioperative deaths is the third leading cause of death globally, only after heart disease and stroke. So this is again where what's important is that it's not just that when surgery is not available people are dying, but even when it is available, if it's not good quality, if it's not safe surgery, if it's not affordable, people are going to die, right? And that kind of burden of mortality is much higher than what we had imagined previously. So avoidable burden as well. So together these two kind of like form a basic idea of avoidable burden, which is pretty huge when you compare it to other non-communicable or even communicable diseases. The second problem that I want to talk about is the access problem. As we, I guess, kind of like noted previously, one of the biggest findings that the Lancet Commission came up with was through a modeling exercise. They were able to show that over 5 billion people globally lack timely access to safe and affordable surgical care. I kind of want to focus a little bit on what do we mean by access here. So we kind of have a multi-dimensional or composite idea of access in case of global surgery. A couple of things that are important are: A, people should be able to reach the hospital in a timely manner. This is particularly important when it comes to emergency surgical services, right? B, once they reach a once they reach a facility, once they reach a hospital, the facility should have enough resources to deal with that person, right? And then we are talking about different kinds of resources, from physical infrastructure to availability of surgeons, nurses, anesthesiologists, uh, and even going beyond that into some of the process indicators such as surgical safety and quality, right? So that's kind of like the idea of like capacity of a surgical system. The next idea in terms of access is affordability. A lot of times people do not access surgical care even when they need it because it's unaffordable for them. So it's kind of a composite of timely surgery, capacity, safety, and affordability. As you can see in the map here on the left, you'll see that almost all of Africa and large chunk of Asia is deep dark red. And if you kind of go into the percentages, the basic idea is that over 90% of people in these countries lack access to surgical care as we have defined access in this case. Okay. On the table that you see, you'll see that the greatest proportion of kind of like people who lack access is of course in low income countries, and geographically it's kind of like this region and then some part of this region, and after that it's kind of lower middle income countries, which also includes India. Okay, the third part of the problem is the economic problem. So the basic idea which has been developing in global health is that a good way to look at health, which kind of can convince uh, funders and which can convince the larger society and which can convince the finance ministries of different countries, is to talk about health in terms of money, because that's a language that people globally understand, right? Then if we kind of like adjust to that idea, the next step in that process is to understand that people who are not feeling well cannot contribute enough to economy, which in turn results in economic loss for the country. This can be captured as GDP loss as well, right? So from that logic, there is a specific approach to calculating like these losses called value of lost output. And when we say output, this is kind of in terms of economic output, right? What we know is that the cumulative losses uh, for people who are denied access to surgery will result over $20 trillion across 128 countries, mostly LMICs, till 2030. And if as you can see, when we are talking about annual GDP losses, even those, let's talk about 2023, we are talking about an annual GDP loss of over $1 trillion because people cannot access surgical care, which means they are going to be uh, deceased for longer periods of time, or which means that they are going to face death. And both of those consequences kind of harm a country's economy. There is also, on the right, there is also distribution of how these losses look like across major disease conditions which can be treated surgically. So gastrointestinal disorders, injuries, which form a large chunk. And in terms of injuries, a big chunk in terms of absolute count comes from India because of road traffic accidents in our country, and because just the larger population size, as well as the large size of young population in the country. All right. In the next part, I kind of want to focus on the idea that it's a big problem. We now know that it's a big problem, but still a larger issue that we are facing is that there is neglection towards this problem, and the neglection kind of keeps coming up in several areas in terms of policy making, in terms of funding, in terms of public awareness. So hopefully this sessions like these and conversations like these will at least be able to solve that issue. I kind of want to focus on two examples of neglection here. First is neglection in policy making. So if you remember the plots that we saw till now, in almost every place, injury was above all other causes. But when it comes to how our intergovernmental and international policy documents talk about health issues, you can see that it's exactly inverse. More focus is given on child health, HIV, tuberculosis, and there is almost no focus on anesthesia, burn care, surgery, cesarean injury, among other things. This analysis has been replicated in other parts of the world. People have done this for over 40 African countries have found the same thing. We have done this for India, and we'll talk about that a little bit going ahead. And the result is kind of consistently the same. Our policies still do not focus on surgical care as a thing, and that's the reason why Lancet Commission proposed that there needs to be a vertical plan for SOTA care. The second kind of neglection is through funding, and which is again an important neglection. First thing that I want to mention is that there is not a lot of data to begin with on how much money is being put into global surgery by the countries, or even in terms of what's considered aid or developmental assistance for health, right? From whatever limited data that we have available, again, what we know is that just looking at trauma care, the developmental assistance for health for disability adjusted life year, which is a way of looking at morbidity and mortality due to a disease condition, it's less than $1 per one DALI. And if for point of comparison, you can see that it's about $10 for malaria, 25 for TB, 41 for HIV, and 46 for maternal and child health. So this is again where all the disease burden, the economic burden, all of those plots kind of just get flipped when it comes to what are we funding, right? Mark Schrein, who is a commissioner for LCOGS and who is a distant mentor for me and a collaborator, he wrote an excellent piece in Stat, which is a health magazine in the US, where he kind of also talked about it in terms of how NIH in the US, which is the largest funding body in the US and one of the largest funding bodies in the world, funds global surgery specifically, right? So just kind of like focusing on specific parts, out of 750 million that NIH kind of puts into bigger grants, only 22 million of these go to surgical care delivery or outcomes or surgical disparities. And only one of these grants in 2021 mentioned a country outside US. So that's one out of 1,500 grants in terms of focus that's kind of happening for global surgery. Coming to percentages, this is just 3% of the R01 funding. For people who probably don't have context, R01 are really big grants which kind of fund research and even healthcare delivery projects for about 5 years. And some of these grants kind of run into millions of dollars just individually. So that's only 0.2% of the overall NIH budget, which is going to surgery, and more specifically 0.09 for surgery, which falls under global health. Okay, let's talk about the third part of the problem, why we should focus on global surgery, because it is a solvable problem. One kind of I guess like a pointer towards its solvability is that it's cost effective, cost beneficial, and has positive impact on poverty reduction and development. What we are looking at here are basically like range of cost effectiveness measured as money spent on averting one DALI, right? So if you look at orthopedic surgery, which is at the top, followed by cesarean sections, ophthalmic, hydrocephalus, and a whole bunch of things, the basic idea that I want you to focus on is that the things that are in red or maroon are ones related to surgical care, while the ones which are in blue are not related to surgical care. As we move from 0 to a higher value of that ratio of cost effectiveness, you will see that almost all of these surgical domains have similar cost effectiveness compared to antiretroviral therapy for HIV or even basic vaccinations, right? So again, the idea that surgery is expensive is it's kind of a myth, and it's kind of a misnomer. It's coming from the perspective of patients for whom definitely it's a high burden. But when we try to think about it as a systems problem, and when we try to think about it in terms of investment from governments, investment from different funders, this actually has a very high return on investment, and it's definitely cost effective when it comes to putting all the infrastructure together for averting the mortality and morbidity burden. All right, I want to switch gears quickly and focus a little bit on what's going on in surgical care in India, and just want to give you a flavor of what we have been working on. I started my work by kind of interacting with people who were a big part of the Lancet Commission and who were kind of involved in looking at India in terms of like the Lancet Commission indicators and national SOTA care planning. I love this quote. I love chatting with Dr. Rani Bang, who is a senior OBGYN working in tribal Gadchiroli. She was a part of National Surgical Forum, and what she said was very stark. This was back in 2019. She said that I feel nothing much has moved after the Karad consensus statement, which was a statement put forward by the Indian stakeholders for global surgery. As the global team leaders are changed and nothing is happening in India, at least. It's kind of in similar lines to what we also know from research that Hampus Homer, who conducted this beautiful study looking across countries as to whether countries have done anything with regards to collecting data on surgical care indicators. And what he found was that the data availability was still low after 5 years post commission, and the comparability of these indicators was definitely not there. So we kind of it's kind of like a circular problem that we are dealing with when it comes to global surgery in India. The idea is that Lancet Commission came up with country level estimates through modeling, through data collection. Since then, there was no new data for India, even through like the iterations of the Lancet Commission reports that happen after that. There were no nationwide subnational estimates in 2019. Okay, with regards to, so this is like the research part of it. The policy part of it is that Lancet Commission led something called the National Surgical Forum, which gathered a lot of different people, generated momentum for surgical care planning. It created partnerships among local stakeholders and implemented a whole bunch of activities, created centers for surgical excellence in different parts of the country. They kind of relied more on bottom-up approach, which we know doesn't work best in case of India. So the problem is that we don't have data, so there is no high level policy interest, and there is no policy interest, so we don't have any avenue to collect new data. I also want to focus on evidence for the idea that there is no policy interest. So this is from an analysis which we recently conducted, which hopefully will be out soon. What we see is that across over 30 years of national health policy, from 1983 to 2017, you can see that the analysis is similar to like the graph that I showed earlier. When it comes to anything associated with surgical care, it always stands low than non-surgical care, and that's kind of happening recently as well. Same thing is going on if you look at on the right. Same thing is going on in terms of planning commission, which is an important piece of policy document in India with regards to deciding our 5-year developmental plans, right? Surgical care is consistently low compared to focus on non-surgery health related issues. So across 40 national documents from 1946 to 2017, what we found out was that surgical keywords are just 90 per every keyword compared to 387 mentions for non-surgical keywords. So that's kind of like the policy neglection that we are dealing with towards this important problem. Okay, last few minutes, I just want to focus on some of the things that we have been doing. So since then, my kind of like master's thesis at Duke Global Health Institute focused on understanding access to surgical care through existing data for rural India. And since then, I've been kind of working on this data-driven approach for understanding what's like how the access problem in India looks like. We focus a lot on figuring out existing data sources such as the health management and information system, national sample surveys, but also working on generating awareness and funds towards ways of integrating new data collection methods and working with clinicians as well as policymakers to get them interested into looking at surgical care from a systems perspective. Okay, so just like a very quick summary of what my thesis focused on, and what we found was that in case of focusing on specifically rural India and rural surgery, when it comes to just physical geographical access to surgical care facilities, we are doing pretty well. Ideally, we are supposed to be at 100%, but over 99 is also pretty great. One caveat though is that we are just talking about geographical access. We are not talking about what happens when they reach that place. Is the place active? Does the place have enough resources or not? That's something that, by the way, we are now looking into it, at least for I think about like 700 district hospitals across the country. Then the second thing that we looked at was how many surgeries. And when we say major surgeries, we are talking about the ones which require general or spinal anesthesia. So how many major surgeries are happening in the country, and how do they compare to this benchmark that Lancet Commission came up with, which was 5,000 surgeries per 100,000 people. And we found out that the met need for surgeries in case of India was actually quite abysmal. It was just 6.8% nationally. And even if you look at the plot in the center, you'll see that a lot of that is in like dark brown, which means that yeah, it's like the rate is less than even 1%. The third important problem in case of India is that of affordability. What we found out was that 61% rural surgery seeking households, meaning households who actually went to a healthcare facility to get surgery, faced catastrophic health expenditure after the surgery. This percentage, by the way, is much higher compared to our general catastrophic health expenditure rate, which lies somewhere between 35 to 40% now. So when it comes to surgery, the catastrophic health expenditure proportion is much higher than just general healthcare. We have been kind of working on continuing this work and figuring out the idea of rural and urban disparities in access to surgical care. So one interesting thing that we found out that when you look at how many people are able to reach the facility within 30 minutes, that proportion is significantly less in rural compared to urban. And that rural urban gap kind of starts closing as you raise the bar of like time to travel, right? Our new estimates are more rigorous with regards to surgical met need. We are now looking at major surgeries, also minor surgeries, looking at year-wise trends. What we are seeing is that major surgery trend has been consistent over last 3 years. Total surgeries are going up slightly, which means that minor surgeries, as in those like that do not require general anesthesia, are going up. A large part here is for ophthalmic surgeries, including cataract, right? But district level disparities for major surgical rate kind of now remain still remain the same. There have been definitely improvements here though. And then our new estimates for catastrophic expenditure kind of do something called error correction with regards to how will you accurately estimate at the district level how many people are facing catastrophic expenditure. And again, we see a lot of different geographical disparities across districts, but generally almost all states have a very high prevalence of CHE when it comes to surgeries. All right, we can now move on to question and answers. I have a few question and answers in mind, but I'm going to keep them hidden because I would like to know more from people what they would like to discuss.
So thanks a lot, Siddhesh, for breaking this complex data down to very simple, understandable terms. A couple of questions, which like actually similar questions have come up in the chat boxes regarding PMJ and Ayushman Bharat. So you mentioned accessibility is sort of improving in India, and at the rural urban level, we are still doing decent when it comes to reaching a health facility within 2 hours. But again, affordability is something you brought up. So with PMJ coming in, firstly, the question is how many essential surgery packages are there in PMJ? And if proper implementation of PMJ, Ayushman Bharat, will that help in improving global surgery, have a better impact on global surgery, or this in the Indian context?
Yeah, that's an excellent question. So we have some ongoing work on PMJ and specifically surgical care within PMJ. PMJ definitely has a lot of focus on surgical care. Over 70% of all packages are can be categorized as surgical packages. So there's definitely heavy focus on that. In terms of evidence with regards to specifically out-of-pocket expenditure, there is very limited evidence as of now that PMJ has done anything much towards reduction of out-of-pocket expenditure. What it has done is that uh, it has improved the issue of utilization of services. So for instance, earlier people who would not have been able to get treatment at certain hospital, now they are able to do that. With regards to how much that leads to reduction in out-of-pocket expenditure at a population level, that's still largely an open question. I have colleagues at ASAR who are working on PMJ extensively, and based on that work, I think it's still in very early years with regards to having any impact. Uh, One of the things that I would like to say with regards to PMJ is that it's kind of looking at this so-called bottom 40% of the Indian population, uh, bottom 40 in terms of socio-economic and demographic indicators, right? Uh, when we look at that population, within that there are certain equity concerns. So for instance, one of the things that multiple studies that have happened since the uh, since like the advent of PMJ, uh, including some of our analyses, have shown that a large chunk of PMJ beneficiaries, or rather, let me put it this way: when it comes to eligible beneficiaries, there is like almost an equal split with regards to men and women, right, for PMJ. But when it comes to people who have utilized services, uh, there is a greater chunk of eligible men who have utilized those services. So I think what we are observing is that within that population which can benefit from PMJ, we have already started seeing inequities when it comes to uh, utilizing surgical care.
But that sort of is true, I feel, for other cases. Well, recently a study by Tata Mumbai showed that even cancer care is more accessible by men rather than women. So I think inequity when it comes to gender is just a social context in India. There's another comment in the chat box which mentions that in the context of districts in India, HMIS does not have any indicators for surgical care, which means there is no data being collected for the same. Any thoughts on that?
Yeah. So HMIS has some crude data when it comes to surgical care. So for instance, a lot of analysis that we do, including like some of the plots that I showed for surgical need, those are using data from HMIS. Problem with HMIS data, there are multiple problems. One problem with HMIS data is that we know from some data audits that it's low quality data, and there is no good way of kind of ascertaining good quality, at least right now, at low cost. So I think quality data is an issue. The second thing is that there is also an element of data incompleteness. So for instance, facilities that come under HMIS, uh, like the proportion of those facilities in India is not over. My guess is that it's probably a bit over 50% now. Back in 2014, it was less than 30%. So also a lot of facilities that are enrolled under current HMIS system are public facilities. Very few private facilities come under HMIS as of now. So I think like data completeness, data quality, those are the issues. One important surgical care indicator that should be included in HMIS, and that's something that we have been petitioning for, is the perioperative mortality rate, in hospital mortality, but also mortality rates at 30 days. That's absolutely vital to figure out the quality of surgical care being provided, and just like even the safety. There is some data on surgical site infections, but again, that's questionable data. So I kind of agree with like the larger theme of that comment, that not a lot of data is present, but I think there is some data there.
There's a question by Samruddha. Samruddha, why don't you unmute yourself and ask your question?
So with reference to the presentation, you said that data availability and missing data and incomplete data is a very big problem. What can be done at the grassroots level, like for example, at the primary healthcare center level or a tertiary healthcare center level, to fill these gaps? And how would one go about doing that? Getting involved as such in such data collection?
Yeah, Samruddha, thanks for that question. I think that's an excellent question to think about data from a grassroots level perspective. And that's not happening a lot in India, to be honest. So I think there are multiple solutions to the problem. One solution is definitely kind of more top down in terms of asking the government to do its job correctly and appropriately, right? Uh, for instance, a lot of data collection that you see now has been not just surgical care, but just generally data collection, even within health, beyond health, is a result of years of, I would say, advocacy and protest for transparency and accountability that has happened around the world, right? So I feel like there definitely needs to be continuation of those efforts, and maybe even the revival of those efforts when it comes to providing good quality, transparent health data from the platforms that are available. So that's one thing. And that, I'll say, that kind of comes to a more of an ethos of social participation. For instance, people who are actively filling in data into HMIS, healthcare providers, interns, nurses, students, right? There needs to be better training, there needs to be better vigilance among them for ensuring quality, right? So there is that. Another way to deal with the problem is to actually invest in alternative ways of data management systems. Now, this is something that India has not been very proactive at, but some of the other countries that are not economically well to do have actually looked into this, because to begin with, the government does not have an option of spending its own money on data collection. So engaging good funders, engaging good non-profits, engaging good tech firms is very, very important here with regards to like primary data collection. One way of doing that is also to not always think about grand ideas, but to actually focus on healthcare centers that you are affiliated with, right? So for instance, some of the healthcare centers have started creating registries for their own places where they can keep a track of surgical indicators that they are interested in. Now, this is just one place which probably has a patient load of like a few hundred patients in entire month, but over time that actually builds up. Not just that, but we have seen examples where such initiatives have kind of act as stalwarts and exemplars for their communities to propagate that culture, right? So I think investing in alternative mechanisms, but also taking ownership of your own health center is very important here.
There's another question by Seema Biswas. Why don't you unmute yourself, Seema, and just ask your question?
Thank you very much. And thank you very much for this wonderful talk. What infrastructure improvements are needed in India to improve surgical outcome in both urban settings and also in the rural areas?
Okay, so I'll just repeat her question in case you
Sure.
don't
Yeah,
understand.
thanks. Yeah.
So she's basically trying to ask what infrastructure improvements are needed in India when you look from a rural and an urban perspective. So where are we lacking and what can be done?
Yeah, I think there are a bunch of places where infrastructure improvement is needed, like a whole array of areas where we could benefit. Couple that come to my mind based on some of the recent discussions. One is definitely that India, when it comes to number of ambulances per capita, right, or per 1,000 people or whatever, India kind of falls very low on that chart globally. So investing in better ambulance services is like should definitely be high priority, especially for rural and remote areas. What we see in our access to care work is that there are certain places which are like literally hyper clusters of accessibility, right? That the density of surgical care facilities on a patch of, let's say, 20 kilometers of road is as high as 5 facilities per kilometer. And then 50 kilometers out of that road, you will find no surgical care facility. So, and in case of India, I don't think that's an exception. I think that's the norm that we have these dense clusters of healthcare in certain parts of our metropolitan, but also as well as like tier 2 cities now, and few kilometers out of those areas, and you kind of see deserts when it comes to healthcare, when it even comes to pharmacies, right? So investing in better ambulance services is definitely like a thing that I would say. Second thing is that there is something called WHO surgical safety checklist. Now, this is something that a lot of countries have adopted. The idea is very simple. This is like a 15 or 16, I guess, questions checklist. But before, during, and after the surgery, you're just supposed to tick things on there as to whether you did this step or not. All right. India has adopted it, and we do kind of mention it in like some of our clinical management protocols now. But very honestly, like I do not see active examples of people using that. We know from evidence that use of surgical safety checklist has led to improvement in surgical safety and quality in other places. So I would say investing in using that checklist and kind of figuring out a way of validating that it has been used is very important. The Indian Public Health System guidelines, IPHS guidelines, which kind of govern a whole bunch of public health facilities, especially in rural areas in India, actually explicitly say, and these are from 2008, revised in 2012. So they are actually very progressive and actually mention that surgical care, especially essential surgery, is desirable at community health centers. And in fact, a smaller component of essential surgery is also desirable at PHCs in some of the bigger districts, right? I do not think that there has been a lot of progress and actual monitoring and evaluation with regards to whether our community and primary healthcare centers are sticking by those guidelines or not. So I think a lot of focus, instead of just putting in money, a lot of focus and resources has to be towards creating these monitoring and vigilance systems, maybe even social accountability systems, right? Where groups of consumers can actually ask hospitals as to how they are maintaining themselves, especially public hospitals. I think more investment needs to be into that for ensuring that we have good quality and optimal infrastructure.
There's one really important comment that Hardik has made, is that when we are studying community medicine in our MBBS undergrad course, we see a lot of national programs for TB, vector-borne diseases, malaria, things like that. But global surgery word doesn't come up anywhere actually in the textbook. And I think that's something going forward, education needs to sort of reform accordingly, where global surgery is brought into our education system. There are a couple of more questions. One is that, what role does PPP, private-public partnership, play in this context of the whole global surgery in India?
Oh, well, I mean, short answer would be huge role. I think if we are ever to achieve anything close to universal surgical care in India, it absolutely cannot be done without involvement of private sector. To be honest, I do not know of very good examples with regards to actual public-private partnerships. Hospitals refer patients that they cannot handle to each other. and that's as much a partnership that I have seen. There are like a few very rare examples of institutional partnerships. So I think our main problem with regards to not just surgical care but broader healthcare is that we have a huge private sector that is responsible for healthcare delivery in India. It's kind of like fragmented from public healthcare system. Figuring out ways to integrate those is very important. We also need to figure out ways to give our private sector a chance to like handle its own self and operate according to like market conditions and constraints. But at the same time, I think we are kind of reaching a point where there needs to be better regulation when it comes to healthcare expenses in private sector. So I would say like partnership is bit of a long-term goal. Like initial steps need to be regulation and kind of removing some of the fragmentation.
There is another question. I think this will be the last question that we'll take is what is the scenario with respect to health workforce when we talk about surgical care in India? And what role does medical and nursing education play in this situation?
Oh, I love that question. That's a brilliant question. And I wish I had like enough time. Like surgical care workforce is like a very active area of research that we focus on. We have a brilliant research member at ASAR, Shirish Rao, who has been working very hard on looking at surgical care workforce. Not just that, but also surgical obstetrics and anesthesia care, PG level and super specialty level training spots, right? And comparing those with regards to other medical training spots. Again, short answer, not very good. Lancet Commission recommends that there should be at least 20 surgeons, obstetricians, and anesthesiologists per 100,000 people in a country. And this is kind of based on the idea that with at least that number, you will be able to achieve the maternal mortality target and a bunch of other child mortality targets that are our SDG goals, right? Based on like recent data, what we know is that that number for India stands somewhere close to, I think 6.9 or like 7 surgeons, obstetricians, and anesthesiologists compared to 20. For UHC, the targeted number is 40 per 100,000. So we have like a really long way to go. I just recently this morning read that like a whole bunch of neurosurgery spots are vacant this year. So I think that's kind of also interesting because compared to other countries, this is a very unique scenario where super specialty surgical training spots in India are vacant. So I think there is like also a clear, I mean, we definitely have like supply problems, but it looks like we also have demand problems when it comes to students interested in pursuing some of these branches.
So I think that was the last question that we could take because we already crossed our 1 hour mark. If you don't mind, if you could just mention your email ID in the chat box, if anybody wants to reach out for any other queries that they might have.
Sure.
They can probably write to you. And thanks a lot, Siddhesh. This was an extremely important session, and I think you did a great job by explaining it in such clear and crystal clear terms. So thanks a lot, and thank you everybody for joining us today is I think Tuesday, on a Tuesday evening because it's Wednesday evening. Because usually we have our sessions on the weekend, and Saturday is a more free day. But joining on a weekday evening, thank you everybody. And there's a small feedback form which I'll be sharing in the chat box. Before you leave, kindly fill that feedback form as well so we can sort of know how we can improve our sessions going forward. I've shared the link in the chat box. Please fill this form, and if there is any other comment, query, you can write to me at parth.sharma@nivarna.org. And Siddhesh is also in his email ID. We'll be happy to take any other feedback that you might have. So thanks a lot, Siddhesh, once again. And
Yeah, thank you so much for having me, and thanks everyone for joining in and yeah, putting forward some really interesting and important questions. Thanks so much.
thank you, and have a good day. Bye.
Bye bye.